Assalamu alaikum. The communication day. Starting by the scenario, Mrs. Rose, seen by the palliative care, and switch from oral morphine to subcutaneous pump morphine for her pains with metastatic lung cancer. You are speaking with the son of Mrs. Rose. His name is Mr. Ahmed. You are the senior host officer in the ward. Address Mr. Ahmed concern. We can start after sharing timer. Okay, ready?
Okay, ready.
Yes, here you go.
Yeah. Hello, my name is Dr. Stara. I'm one of the doctors in the clinic today.
Hi, doctor.
Hello. Yes. Can I know that you are Mr. Ahmed, the son of Mrs. Rose?
Yes, I am.
Yes. So we are here today to discuss the condition of Mrs. Rose with you. Can I know if you are the next of kin for her?
Yes, I am.
Okay. So just to confirm, of course, she's aware that we are here and speaking about her condition. That's right?
Yes, yes.
Okay. So can you tell me what do you know about Mrs. Rose's condition, Mr. Ahmed?
Yes, I know that she has this spreading cancer, and she is quite suffering, doctor, from her headaches, really bad headaches, and I know that her headaches. This is the first time she gets like these headaches. Yeah, that's what I know about.
Okay. I'm really sorry for her condition, Mr. Ahmed. So as you're aware, we have Mrs. Rose is really having the condition of like a lot of spread of her lung cancer in many parts of her body, and this has caused her to have like symptoms of pain. We have tried in the beginning to give her some morphine medication for her, which is in a tablet form that she can swallow. But after assessing her, our team assessed her, and we really feel that this tablet form is not really helping her. Is that how you feel also, Mr. Ahmed?
Yeah. I'm not fully aware about this difference, but I feel overall she's quite not feeling well to me. She's also in pain. She's also sleepy. Yeah.
Yes. So yes, that's what happened, Mr. Ahmed. Actually, after discussing the situation with Mrs. Rose, we have decided to shift this tablet form to another form of morphine, which is called subcutaneous form. Don't mind the name of the medical name. This is like giving her the morphine under her skin. Like we give her continuously under her skin, just to try to make her more comfortable and make her pain go away.
Okay.
That's okay. So what we are doing actually is we are putting a needle below her skin, and as I told you, we're giving this medication in a specific doses below the skin. Of course, this will make her pain so much better, and we can control her pain. But on the other side, this continuous form can really make her feel like dizzy, you can feel her more sleepy, and her communication with you could be less, because morphine, as it's a very great medication to control the pain, on the other side, it can lead to more sleepiness, as I told you, being dizzy. So yeah, you can notice these like manifestations or her when you are visiting her. Is that okay with you, Mr. Ahmad?
Yes, okay with me, but she's already drowsy before this new medication shifted. That will make her like to I know I suppose in a much more bad drowsiness. I'm afraid about her.
I appreciate your concern, really, Mr. Ahmad, but as you're fully aware, Mrs. Rose's condition is really advanced. And yes, as you have said, she has been drowsy before because of this, like lung cancer going to other parts of her body, like her brain. But just as you're well aware, because of this advanced condition, our concern really is making your mother really comfortable as much as possible. So
Okay.
this morphine will really help her regarding her pain, because she was really suffering with this pain. So we feel our team have assessed her, and we think it's better to keep her more comfortable with this pain. And
Are you killing my mom?
no, be assured, Mrs. I appreciate your concern, Mr. Ahmed, really, but be assured that we have one of the best teams in this hospital that can treat such cases, and it's just morphine is just for the control of the pain, not uh, we are trying to help your mother and trying to make her more comfortable.
Okay.
It's not real. It cannot cause the side effect, as I told you, or the problem is only making her more drowsy or more sleepy. But be assured that we are giving in the proper way and the proper doses, and we are following up her and giving her monitoring that uh, uh, we cannot, and it will not lead. We will try to avoid any harmful way for her. Be assured about that.
Okay. And what can I expect apart from the being sleepy? Will that make other effects?
So as I told you, the morphine can lead her to be more sleepy, more drowsy. The communication with you can be less.
Will I need to bring my family? Is she dying soon?
We think that yes, because of I'm sorry to tell you that Mr. Ahmed, because of her really advanced condition, it's better to get her family to meet her as soon as possible. Better to do that, especially she can have this drowsiness, more drowsiness with the original condition. With her original condition, can lead more drowsiness, and also this morphine can lead her to be more dizzy. So if you can ask them to come like as soon as possible, and we can make the doses of the morphine now. We can make it like very when they are willing to meet her or they can meet her, we can make just the appropriate doses to make her pain free, so that the communication with your family can be better. How do you feel about that, Mr. Ahmed?
Okay, that's all right.
Okay. So can I ask you who is the one who's taking care of her at home?
She is she has carers. She's all right.
Okay. So any more concern, Mr. Ahmed, regarding our meeting?
No, thank you.
Okay. so that you know, we are going to give you some like brochures, and we are going to give you like websites that can explain more about this, like so, like this medication morphine we're giving under the skin to help you understand more about this condition. Also, we are going to give you the hospital number, just to, if you have any more questions or any more concerns you want to address to us, we are going to help you regarding any questions you have. And we're going to address any questions you have. Is that okay with you, Mr. Ahmed?
Okay.
Sorry, I don't think.
What were you going to ask?
I was going to ask any advanced directive, but I think
I don't think it will be useful in this
yes.
scenario, but let's discuss. You did well. So can
Yeah,
you?
time is up.
Yeah.
You want to add any concern, Dr. Abdullah, or you will comment?
No concerns. I will discuss,
Oh,
I
okay.
think.
Okay, yeah, you can start.
Yeah. So you did well. You covered most of issues. You did the good introduction. You asked the permission of the next in kin. You don't need to double check with the next in kin. Just once, that's enough. You can, what has been done, you just discussed what has been done, and you have checked the knowledge of the next in kin. That's very important. And the patient, the next in kin told you that he knows much of the background, so he helped you in that he knows it's spreading metastatic already, but he doesn't know like it's terminal or for end of life or in terminal days. It doesn't necessarily mean that she's in the crisis of end of life. There's a difference, but she's already terminal. That may mean weeks, mean days. We don't know. So, and he doesn't know the discussions that have been run recently, consultation from the palliative team plans. So you will need to focus on that with the discussion. So you jumped immediately, I think, to the decision of the morphine. It will be easier if you prepared him to the point that we have run the discussions. We brought a team for the best comfort of your mother. And actually, I'm sorry that she is, as you said, has spreading cancer. That means it's she is. I'm really sorry that she is approaching her end of life, and we have run a discussion for that, for her best of benefits and comfort with the team called palliative teams, and they are specialized in the best comfort and symptomatic treatment. And actually, they decide we have a couple of decisions for that, and he may ask you, okay, can you tell me more about that? And so you will say you will bring the change in medications. We will put her on regular medications, continuous painkiller, very strong painkillers, and we will. So we are already giving her per need medications, but that's not enough. As you know, she's suffering, complaining of headaches and bad headaches. So we will put her, and that's based on the discussion from the palliative team. So we have run a common discussion, this decision from both of us that she needs continuous medications for her comfort, and that is called continuous morphine. You don't need to explain that under the skin in the detail, like just continuous medication. That's very it has a good effect, but it may not terminate the headache like totally. The issue is that she will be very drowsy. She may be more drowsy than more she is already on drowsiness. but she will be drowsy. She may be more constipated. You will need to explain all the side effects. She will be, she may vomit. She will be sick, nausea, and we will give medications for this sickness. We will give medication. We may give medications for the constipation. But as you know, so here's a very tricky point that you need to say, I'm really sorry, as you know, that she's in terminal days or weeks. We want her the best comfort, and actually we can't have other measures than that. This is the best of her. This is to put her to die in a peaceful way, because as you know, there is no interventions, there is no other treatments. So that's the morphine, the symptom, as part of symptom treatment. There is something called double doctrine rule. Double doctrine, like something with two swords, double sword edge. So the morphine has benefits and harms, adverse effects. When he says, okay, are you killing my mom? No, I'm sorry for that. I'm really sorry that you feel that, but it's because we will be very careful. We will give in a safe dose. We will start slow, and we will see how much does she need, and we may titrate or build up the dose according to what is safe for her and according to her body response. That's the message. So it's a balance between the adverse effects and the benefits, and you need to mention all the adverse effects, and then you got that you summarized in a clear way. And yeah, and that's all. Thank you.
Okay, thank you, Dr. Abdullah. Yeah, yes, thank you, Dr. Abdullah. Thank you, Dr. Sarah, as well. Before starting, yeah, please write the scenario down in the chat box, Dr. Sarah and Abdullah. Then I will start commenting, because I think this scenario is new. I don't know, was it exam experience or just book, Dr. Abdullah?
No, it's from I looked in past tests.
Yeah, okay. Yeah, I think also it's not common, but anyway, we had to learn how to talk about palliative from the point of analgesia or painkiller or comfort care. Let's say, yeah, it's like comfort care, and the patient will die in peace. This is by our term, but you can't say this to the patient. You just tell the relative, sorry. You will just tell her or tell him that we are doing our best to be sure that Mrs. Rose will not feel any pain at all, and she will be comfort uh, all through, as long as she is with us in the hospital. So this is the best way, by converting the morphine from the oral route or through the mouth to the other one, which is subcutaneous, means that under the skin. Okay, so this is the way how to explain.
Dr. Bassem, your voice is interrupting.
Yeah. Okay. Sorry. So yes, as I said, to be comfort as long as she is with us, and to be not feeling any pain at all. And the other thing, we don't want her to suffer. She suffered a lot because of this pain, because of the uh, what's called the headache. So the best interest for her now is to let her not to suffer by anyone. Are you going to kill my mother? No, don't worry. We are not here to do so. We are here to let her or to be sure that she comfort all her. Okay, this is the way. Let's talk about the performance. Dr. Sarah started the introduction, and then a question for the next of kin was a good question also. Also, she asked a good question. Mrs. Rose aware about our meeting. Yes, you can assume that because this is also one of the confidentiality, and you are going to discuss her condition. Then you ask about his the knowledge about the mother condition and the expectation. Try to ask it. He might give you idea what's ongoing. He might say, yes, I want her not to suffer more. So he's preparing you to give him the option and the solution for the suffering she is on now. I prefer to do that, Dr. Sarah, to just give him a preparation for what he will listen from you and what he will hear from you. It's the task. And if you ask him this question, you make it easy for yourself to prepare the switching from the oral to the subcutaneous. This is regarding the first point that you missed. So the expectation or any idea about what's ongoing, do you have any expectation about this meeting like that? Okay, the next thing, the questions, I think Dr. Sarah asked because she didn't and we didn't also practice this scenario before. All question was okay, the sleepy all the time, yes, the drowsiness will be also there, the dizziness, the GI upset, the constipation as well. But after mentioning the palliative team, as Dr. Abdullah said, this is also yeah better to say palliative team sit with together about your mother condition and decided to do that. And the decision is to switch from this to this. This is our multidisciplinary team. They are expert team, professional. They know how to manage the pain in such condition which your mom is suffering from. I think the others question and concern were okay, killing my mom. No, we are just giving her the rest in the days, the coming days. We don't want her to suffer more. She already suffered for a long time from this cancer, the pains and the headaches. We don't want to do to feel that in the coming mm, days or hours or whatever. The other effect, yes, Dr. Abdullah mentioned the GI upset and the sickness and so on. Yeah, I want some of the family to come. Yes, okay, it's okay, they can come, and even we can delay the effect if the drowsiness will happen. Yeah, we can give the chance for your family to visit and to sit with them, and if we want to see her before she feels this drowsiness. The question for who's taking care of her, this is by Dr. Sarah. Yes, okay, you can ask this question. But if you have time, for me, if I have time, advance directly. I will ask the advance directly. Even it will not change the decision because already end of life care. But at least if the relative or if she has advance directive to do to go home or to die at home, it will be easier for the patient and for the family to be with them all the time, even with the morphine pump or without morphine pump, whatever. But if she said or if he said, I want my mom, or she said, I want to die at home, I think it will be easier to be with them, and you will be all around here better than in the hospital. This is my opinion. I will not ask about lasting power of attorney because this one it will not change the decision. But for the advanced directive, it might ease uh, the uh, the decision to go home and let her die in between. I mean, with the family members. This is my opinion, Dr. Abdul. I don't know if they mentioned this
Yeah.
point in the past list or no, but if I have such scenario, I will go through it
Okay. I
because this is
agree.
the time.
Yeah.
Yeah, this is the time to speak about. I don't think
Okay.
in this scenario you will miss the advanced directive because
Mhm.
yes, the patient is already dying, and any patient in the terminal and the last moment or minutes or hours
Mhm. Mhm.
or days or weeks, the question will be valid. So this is my opinion. Apart from this, Dr. Sarah did great, yeah. And thank you for this, Dr. Abdullah. Any
Thank you.
other comments, any question from others? Yeah, Dr. Abdullah, the scenario written in the chat box, Mr. Edward Watson, the wife, Mrs. Watson, you are the medical doctor in the
Yeah.
general ward. Watson presents the emergency 2 weeks ago, few weeks history of worsening, short of breath and chest tightness. He had background history of diabetes, hypertension, underwent surgery for cabbage. Mr. Watson also had a history of exposure to asbestos as part of his previous job in the asbestos industry. He was reviewed by junior doctor on assessment. Oxygen saturation was normal in room air. ECG was also normal. CT chest without contrast showed fibrosis and asbestos flakes. Mr. Watson was then seen by a cardiology colleague who gave him appointment for outpatient assessment for ischemic heart disease. And he was referred to the respiratory physician for outpatient pulmonary function test. Unfortunately, a few days later, after discharge, he passed away. Postmortem examination revealed multiple pulmonary embolism. The task speak with Mrs. Watson, explain the situation, and address any question concern she may have. Yes, nice scenario. I remember this scenario.
Nice
Okay,
scenario.
yeah. Well, good luck. Take 2 minutes, and
Yeah.
we will have the practice after 2 minutes. Ready? Dr. Abdullah?
Yeah.
Okay. Let's go ahead.
Hello.
Hello?
I'm Hello. I'm Doctor. My name is Dr. Almanla. I am one of the medical doctors here. Am I speaking with Mrs. Watson?
Yes, I am on the one, doctor.
I'm here to discuss with you about Mr. Watson. Uh, what do you know about his condition?
What I know, doctor, that you killed my husband. You killed him.
I'm really sorry. I'm really terribly sorry for your loss, Mrs. Watson. Here that we are here to discuss. Um, could you tell me what do you know? What happened?
What I know, doctor, that my husband came to you and he had this difficulty breathing. And what your doctor did is just sent him home. He did nothing for him, doctor. And after that, he suddenly died. And then they are telling me he had this clot in the channels and you never did anything for him.
And so, Mrs. Watson, what do you expect that I may tell you?
I'm not expecting anything, doctor. I know that you did a mistake and I'm going to complain. It's my right, right?
I will answer with you about that. Just let me explain first uh, about him. So, he, he had um, actually he was seen by the doctor. You are right, and he did for him assessment that time. He was told he wasn't on oxygen, and his vitals and heart rate were normal. And as in that situation, given that he had also a workup of he had a workup of possible lung fibrosis and scarring, I mean, from the asbestos, and he had a problem with the heart, with the blood channel, with the blood, with the heart attacks, and what we call ischemic heart disease. So the problem is that in this situation, shortness of breath may look may not be easily found as a clot as a culprit in his case. Let me be more clear. The doctor that saw him in that time, it was really difficult for him to think about clot because usually we have like a point checklist for a suspicion of clot, and how do we suspect and how do we rule out? And in his case, it wasn't very an easy job. Are you getting me?
Yes, I hear, doctor.
Now, actually, as the as you know that there has been a post-mortem an examination of his body. Do you know that?
Yes, doctor, that's what I told you.
Yes.
I told you that they informed me that you missed this big trouble that he had, this big problem that he had, this clot in his blood channels, and you never did anything for it. And now he's dead, doctor. He's dead.
And I'm really sorry for I'm really sorry for what happened. And again, in these situations, I'm not defending my colleagues. there must be, if the time came back, that there must be something that has been, there should be done more instead of what has been done. And in order not to have missed that, but given that too many things can lead, have had his shortness of breath at that time, in his case, it would not be really easy job to know exactly why he was short of breath. Is it a clot, or is it the lung clearing in his chest, or is it the heart attack? But again, if there must be some more blood tests, more that can, and again, there is another point. If that scan was discovering that clot that time, this doesn't mean that it may prevent the death. And now this, I'm speaking actually, in some cases we see in that the case, there must be difficult, challenging things that it's already in a difficult to manage. And even if the diagnosis was discovered, and the treatment was given, say, blood thinners, we're not sure if that may prevent the death that time. I'm really sorry to say that in that way.
I'm not convinced, doctor. I want to complain, please. Please, I want to complain. It's your mistake,
Yes,
and you're covering
yes.
for yourself. And I want to complain. You're just covering for yourself,
Sure.
doctor.
Sure.
You're not
Okay.
even admitting that it was your mistake.
Sure. Okay. Well, again, we will. Okay. Sorry. Oh, what can I? Well, I want to tell you, Mrs. Watson. I'm really sorry, and I apologize for what happened. And I'm apologizing for what happened in the name of all the team, on behalf of everybody. And actually, we need to do more meetings to discuss what happened. We have first of all, you can put a complaint in. You can put a complaint in an independent place that's independent to our practice area. It's called Patient Advisory Liaison Services, and they check the complaints and they see they can deal with the complaints in a real sensitive way, really sensitively they deal with these issues. And so that's also in our hospital, we will do a meeting with a specific team called root cause analysis. They can check. Its idea is that they discuss to improve even our standards of
1 minute
practice,
remaining.
so that we can see how can we improve. Is that all right?
Okay, doctor. Please show me this office.
Yeah, I will guide you to that. Can you have any concern? Do you have any concern with me?
No, doctor.
Okay. I'm really sorry again for your loss, and we we are here to help you as a family for any support that you need.
Okay, doctor.
Okay, time is up. Yeah.
Okay.
Yes.
I'm sorry. I'm really
Okay,
sorry,
This
but
is complicated,
this happened.
Dr.
yeah, it's okay. We have to because the
I'm
scenario
sorry.
also need angry relative. Yes, it's already lost. So start the comment, Dr. Sarah, then I will comment.
So, yeah, this is the case. Actually, it's not medical error. It's only about dealing with angry patient and sorry, angry relative, and trying to give her explanation about what happened. But the idea about what have or who have done this scenario, it was in one of the diets last year. They're telling that this surrogate was really trying to push the doctor to admit that it was a mistake. So it's about giving her condolences, trying to calm her down, and to just explain what happened. That we're not defending ourselves, but what happened that he presented with such condition, this is shortness of breath, and I'm really sorry, but our team really tried to. Uh, we are not apologizing. We're just trying to calm her down, right? We are not telling her that this is a medical error because it's not. There is nothing in the any investigation that was done at the time showed that he had any blood clots in the channel or any pulmonary embolism. Everything was going in the direction that it was only like lung fibrosis and like maybe it can be that.
Uncertainty.
Yes, and also the ischemic heart disease could have been worsening, but nothing also in the acute state or acute
Okay.
condition proved to have worsening of ischemic heart disease. And the doctor did the right thing. He did the CT with contrast, and the CT with contrast did not show any blood clot in the channel, only this problem with asbestos. And also, the doctor did the right thing that he referred her for the follow up with the cardiology and the respiratory doctor or the chest doctor, and that's it. During the scenario, your target is to try to calm her down, but you never admit because there is no medical error, and we don't know what happened. Maybe after discharge from the hospital, he developed this pulmonary embolism. We can say that maybe after the discharge of the hospital, we don't know what happened. Maybe he developed this problem, and there was nothing showing that he has this problem during our examination and our investigation. Nothing showed this one. If she's insisting, and still, yeah, actually, they're telling that she kept pushing that she needs you admitting that it is a mistake. She wants from you to apologize to her, but you can't just make like, I'm sorry for your loss. I'm sorry really for what happened. We are really feel bad for what happened to your husband. But we never, this is not a medical error. So we never admit to a medical error. And what we can say that, yes, you can complain and show her to the PALS office and tell her that we are going to do more investigation. We can say that, just more investigation. And if the investigation shows any problem, we are going to tell you. But never admit that this is like negligence or medical error, because this never happened. And because the asbestos, I think some people will suggest that we can tell her that maybe that we will refer her to the office that's responsible for investigating such a complication from the asbestos exposure. But I'm not sure if you can tell her, yeah, maybe you deserve a compensation or not. I'm not sure if you can confirm on her that she deserves the compensation. But just you can tell her that we are going also to refer you to the responsible office to investigate the asbestos exposure and the complication that has happened to your husband from this asbestos exposure. Just to touch it, Actually, the surrogate in this diet was never satisfied. She was always attacking the doctor. She was always pushing him to just admit it was a medical error, which is not. That's it. The doctor did great, actually. Yeah, he tried to calm her down, and his tone was really calming. But she's never satisfied. Yani, this is not the mistake of the doctor. Yani, this is, yani, she has this opinion, and she's trying to push the doctor to the direction of medical error.
Yeah, thank you, Dr. Sarah. Thank you, Dr. Abdullah. I will comment on you now. Okay. First of all, yeah, you are going to talk with not only angry, she has a loss. So the introduction, let's start from the beginning. In the introduction, you ask about her name or the patient name, but you didn't confirm the age or so at least one of the not one both data of the name and the age. You are Mrs. Watson. You are the husband of Mr. Edward Watson. His age, if not written, you can ask, or if written, you can say his age is. Okay. First of all, before saying anything, you just confirm. So immediately start by some condolences. Yes, I am sorry for your loss.
But Dr. Basim, I was thinking she may not know, and that I'm breaking the
No,
bad news.
wait.
I thought that. So,
Unfortunately, few days later, the post-mortem examination revealed a multiple biomalism. Speak with accident special address. Yeah, okay. If not clearly knows that he's dead, yes, you can. Yes, you can start with. Sorry, I also misunderstood. Like she knows already he did.
Yes, when he asked me, I told him that yeah, you killed my husband. There's blood clots in these blood channels, and you did not do anything to him. This is what
So
I
she
tried to
knows
tell
or
him.
not yet? She
Yes, yes,
doesn't
she
know.
knows. She knows. She knows. In the beginning, she told him, You killed my husband.
Yeah.
He had
Okay.
these blood clots in his blood channels, and you never did anything
Yeah.
to him.
Okay. Let's do it in another way, Dr. Abdullah. Okay. You don't know if she knows or not. You can asking how do you feel now? What's how are you like this? Because yes, you are going to break bad news. Okay, let's skip this point of it. What do you know so far about Mr. Watson's condition? Yeah, then she will start to talk. But before that, also you can ask, are you the next of kin? To confirm also she's the one next of kin. So, how are you? Are you the next of kin for Mr. Watson? What do you know about his condition? What happened with him? Then if she start to say like this, you killed my husband. Okay, this time let her finish the talk and immediately be sympathetic as you did. You are too much sympathetic in all the scenario. Okay, so yeah, as you did, I'm sorry for your loss. That's it. Try to calm her down from the beginning because if you left her shouting and attacking, she'll never stop. I'm sorry about your loss, and we are here, all the team, to support you and our all condolences to you and your family. And we are sorry for what happened to Mr. Watson, but not to apologize. As the concern said, here, this is not medical error at all. No mistake in this scenario. And the major thing in this scenario to show her that what happened is already like accidentally PE happened after he discharged. It's not in the previous because the CT will not miss it. And we didn't miss it. And no one misunderstand or no one misdiagnose it. No, it wasn't there. And it might happen anytime because of his condition, ischemic heart disease, cancer, asbestosis, fibrosis. plaques. All these can lead to PE or pulmonary embolism, along with the comorbidity, other comorbidity in the condition. So you will always talk about the background of this idea that it's not mistake. What happened, accident, or it's the accidental finding of pulmonary embolism after it wasn't in the previous CT. So if she attack you again, no, it's a mistake. I want to complain. Yeah, I understand your feelings, Watson. Yes, and try to calm her down. Are you okay? Do you need some support? Do you need any water or tissue? And are you okay now to proceed further? Okay, doctor, proceed. Go ahead. What you want to say? Yeah, yeah. I want to say 1, 2, 3. Which is, yeah, Mr. Watson came and it wasn't there. And after all work of the image scans, we found nothing, and we gave him appointment. However, when he left the hospital, it might happen, and the clot happened while he's not in the hospital, while he was at home, and we found that accidentally in the postmortem follow-up or postmortem study, which is done when we saw him after his death. I think she knows about his death. Why? Because he was at home. So she brought him at hospital with her. I think so. So she knows that he's dead. I think the scenario is clear now. I misunderstood, but it's like that. Patient came from home dead, and the postmortem study already happened, and the result is he is dead because of PE. Not to examine him for if he's dead or no. No, he came already dead, and the postmortem. I think yes. No, it's like I said earlier. You should prepare the hair with condolences from the start. Now the scenario is clear. Patient did at home and came dead. Okay, Dr. Abdullah, I don't think she doesn't know if he's dead or not. Anyway, let's continue the comment. Then, if anyone wants to discuss, we can discuss any other thing. Yeah, you kept defending the doctor. No, our doctor can't expect the blood or no need to defend. What happened is not at all related to the team because it happened after they left or she or he left. So why you are talking about this issue? You will give her the suspicion that or the suspicion that there is a mistake or there is something hidden, something neglected, or something didn't diagnosed well by the treating team when he was in the hospital. No, don't defend him. Nothing happened already. He came and he did a scan. Everything was okay, so he did discharge. That's it. So no need to say no. The doctor misunderstand or he didn't expect. And also, yeah, I agree with Dr. Badi. Not to say if we diagnose it earlier, it wouldn't make a difference. No, it make difference. If diagnosed at the hospital, it will be managed. So it's totally different. If we saw the PE in the CT, the patient will receive the therapeutic, will be seen by pulmonology, intervention, radiology. He will undergo the extraction of this thrombectomy. So it will make a difference, of course. So I also agree with that. Don't say nothing will be different. No, nothing will be different from the point of the asbestos, the plague. He might live longer if not have the PE, but he might die by the either fibrosis, respiratory failure, but it might take longer. Not like PE. PE is an acute event. He will die whenever happens or undiagnosed, for example. But the asbestos, yes, he might live longer and he might also take chemo or radiotherapy or palliative, whatever the reason. But I cannot say it will not make difference. No, there is difference. Okay. Yeah, the complaint at the end. Yes, you have the right to complain. I will guide you to the office, which is called Patient Advice License Services. And here you can also give her a hint about the compensation. By the way, Mr. Watson was working in industry, and this industry made him more exposed to what's called asbestos. And whatever or whosoever working in such area, they are uh, they can deserve a compensation. What to do now? What I can do, doctor? No benefit, whatever the response. Still here, I will guide you to the office responsible for this. What it's called legal advisor. They will tell you how to process the law. That's it. And again, I'm so sorry for your loss. My condolences to you and your family. We are here to support you. We have our bereavement team also. They can sit with you and your family if you need any help, any support. And thank you for the meeting. And what I want also from you, Dr. Abdullah, you are talking in good tone, yes, I know, but be listener. I'm always giving this advice. Be listener, not only talking. To be listener better than being talking. Because yes, you want to talk and to finish the task, but if you didn't hear the concern, you might lose all the marks. So try to listen, and according to the words and the concern, you can answer according to the question, and by this way you will get the all mark. Okay. Of course, after finishing the task. In this scenario, the task depends on the reaction of the relative. What happened, doctor? You will explain. Why he did? You will explain. But no task here to start to defend your colleague. No. The task here is not to do something from your side. The task here is to explain what the patient or the relative understood, and you want to explain and to correct the ideas. Okay? I think, yes, this is the point I wanted to do. Let's see the comment. He clarified, condolences is the most important one. Yes, from the start till the end, repeat it and try to make it like it's very thing concerning from our team, from me, from the whole doctors, like that. Because you know the loss is very hard and painful for the relative. Yeah, thank you all for the comment. Any other comments? Thank you, Dr. Fadi, as well, because yeah, this point also very important to mention. Okay. Any comments? Dr. Abdullah, thank you. If you have any question or you want to explain something, I'm sorry. You want to say something, Dr. Abdullah? You want to add any comment? Yeah, thank you, Dr. Fadi.
Should I ask him here about anyone dependent on him? Anyone need any support?
No, he already is dead. I don't think.
Anyone
give.
dependent on him?
Yes, I know. I was dependent. She is the one in front of you now. She is the one, the wife. Yeah, I mean, if you want to do, invite the bereavement team to sit with her, and you can invite the other family member. Yeah, if any other family member with you, they can come and sit with our team. They can sit with them to support them. Okay.
Okay.
I understand your point. But I don't think the dependence will make sense here. So what I will do?
Because the social markets of the social on the offering here.
Yeah,
how
the
can I
social
offer
here,
in this
yeah,
patient?
Yeah, what you will offer here is the debriefing team. This team is concerned to sit with the family and they can
Again, doctor,
support.
again. The help
Debriefing team. Debriefing team. This team sitting with the
Debriefment team?
family, yeah, and they are supporting them for the bad news, and they are supporting him by spiritual things, religious, I mean, and you know, you understand how they can support them from the point of sadness, and yeah, this is
Yes.
the bereavement team. job, and you will do that. But from your side, just condolences to the family and his to the relative and to the family. Yes,
Thank
I,
you.
I yeah, thank you,
Can
Sheba.
can support if he has children or big family, we can offer help.
Yes, of course, but yeah, by this way, this way, because the next step, yes, if I think this the compensation is much important than the asking who's dependent on him. Okay. Now your job is to deliver the bad news to the wife and to other family members, but not to ask about who's dependent on him. No, if he's sick, for example, we will support him. But already he's dead. So what support you can give? Only the social support by the bereavement team. Okay, I will mention the team in the group, the name of the team in the WhatsApp group.
Yes, thank you. Actually, the mic wasn't working, sorry, so I was trying to. Thank you so much for the nice
No,
comments.
no problem, no
Actually,
problem.
yeah,
Thank you,
it's
too.
learning, but
Yeah. Hmm.
it was little bit so the CT without contrast does not show the PE, does it? And
Okay,
uh,
doesn't, but after 2 weeks, the PE happened. So it's not in the previous CT, right?
the
How
weird
many
thing that
weeks?
it's multiple clots, like multiple BEs, like formed quickly within 2 weeks. So
Yes,
that's
why
what
not?
I.
Yeah, why not?
Mm,
Okay,
yes,
let's
yes.
talk about, for example, the sensitivity and specificity of the CTPA. Will it conclude there is small pulmonary embolism? Yeah, this thing will be also debatable how you will go through it. Didn't show it? No. Whenever we will do CTPA, we will believe the radiologist. If there is, he will read it. But the sensitivity will not talk about. Maybe it will miss a small one, or but it will not miss a lot of PE or not significant. And he will not die from small PE. He will die by major PE, massive pulmonary embolism, not just multiple. Okay.
I think we put CTs just without contrast just to make you question if it's really the
Yes,
mistake.
CTPA. Yeah, in the scenario here, it's meaning that no any mistake. If other image, like example, the patient underwent chest X-ray and they discharged him, and after 2 weeks he had the cardiac arrest and the post-mortem shock. I think this time it could be a mistake. Why they didn't order for CTPA? Okay, because the chest X-ray will not diagnose pulmonary embolism. But since there is pulmonary CTPA and no pulmonary embolism diagnosed in the CT, means that they did everything and it wasn't missed. No, it wasn't there. And the accidental happened after that. Okay?
So yeah, so just to make it like clear to all of us. So here the main value is, so first it's clearly the she knows, then the first words are to condolences, and
Yes,
then
exactly.
all the scenario during all this station, and then
Yes.
bereavement team support, and be it's sympathetic and sorry, but not apologizing at all because it's not
At
an
all.
error. Okay. Okay.
Exactly. Yes.
And I need to explain well that well, I don't need to apologize to defend, but but I need to explain that this scan has been, well, I may not provoke the anger of the patient if I told her that, oh, this scan done 2 weeks after, it may, that time there was no clot, right? This will provoke the anger, maybe.
Yes, yes,
Not good.
it will, yeah, it will accelerate your anger, yes.
Okay.
Okay, he has comorbidity, and the thrombosis what might happen by this comorbidity. It's not only since the previous admission, no.
Okay.
Might happen
Okay.
after wasn't there. Okay. Yeah, thank you,
Yes,
Dr.
yes.
Abdullah. Thank you,
I like
Dr.
these
Sarah.
scenarios. Thank you so much.
Yeah. Medical error scenario will be clear as error isn't. Yes, definitely. Yes, it will be written as it's medical error. Explain the medical error. This is what we practice in the exam scenarios. They are mentioning your task. So is it medical error? They will say this is medical error. Please proceed through. So it will be easier. Not hidden, yes. Okay. Okay. Thank you, Dr. Abdullah again and Dr. Sarah. Anyone has any comment, any question? If no, we can end the session. Thank you, everyone. See you tomorrow. Good luck and good night. Assalamu alaikum.
عليكم السلام.